Welcome to Chapter 5 entitled The Role of Adherence in Pharmaceutical Care. Optimal adherence is often a prerequisite for medication effectiveness and safety. Maximizing medication adherence is one of the core activities of the pharmacist when providing pharmaceutical care. This chapter starts by defining and carefully framing medication adherence and placing the different terms and phases of the patient-medicine relationship into context. It then provides an overview of the factors that impact on medication adherence, the methods available to measure adherence, and above all, the ways through which practitioners may detect medication non-adherence in daily practice. A list of interventions intended to foster adherence is presented, with their categorization, together with their pros and cons for development and implementation in daily practice, highlighting those where there is more experience or evidence of success. Let's begin with an introduction. Adherence to treatment regimens is a key link to improved patient health outcomes. Ensuring adherence is an important role for the pharmacist, and a fundamental component of pharmaceutical care. At every patient encounter, pharmacists have an obligation to monitor adherence and resolve any medication taking issues that patients may have, including non-adherence. Non-adherence is not a condition-specific phenomenon. Low patient adherence to prescribed regimens is a problem which has been observed in a broad range of medical conditions. Depending on the condition and its treatment, patient deviations from therapeutically appropriate treatment regimens can lead to a range of negative humanistic, clinical and economic outcomes. Non-adherence to clinically appropriate treatment regimens has been associated with decreased treatment efficacy, poorer patient outcomes and increased disease burden. It is estimated that only 50% of patients with chronic diseases take or use their medications as prescribed. This, coupled with the growing prevalence and burden of chronic diseases worldwide, emphasizes the significance of the negative consequences of non-adherence for individuals and societies as a whole. Non-adherence represents one of the most significant challenges facing healthcare providers, policymakers and researchers today. We will now focus on defining key adherence-related terms. The complexity of the field of adherence is reflected in the variety of different terms used to account for variations in patients' medication taking. Interestingly, although some of these terms are used interchangeably in the literature, they are in fact unique terms that are varied in scope. And now let's look at compliance. Compliance was, up until recently, the most commonly used term for describing patients' following of treatment instructions. It was first coined in the 1970s and defined as the extent to which a patient's behavior, in terms of taking medications, following diets or executing other lifestyle changes, coincides with the clinical prescription. Despite the widespread use of this term throughout medical and pharmaceutical literature, this conceptualization of patients' medication taking has been the subject of much debate and controversy, primarily due to the term's negative connotations and paternalistic undertones, with many arguing it implies that patients are expected to passively follow doctors' orders and that there is an inequity of power between the two parties. Next we will discuss adherence. The introduction of the term adherence reflected a significant shift towards recognizing the important role of patients in their own healthcare. Adherence emphasizes that patients should be heavily involved in the treatment decisions made. The World Health Organization defines adherence as the extent to which a person's behavior taking medication, following a diet and/or executing lifestyle changes, corresponds with agreed recommendations from a healthcare provider. Perhaps the most important aspect of this definition is the recognition that patients and their healthcare providers need to reach a point of agreement about the course of treatment. Adherence is now understood as a multifaceted construct encompassing patients' understanding of their illness, their belief in the efficacy of a particular treatment, and in their ability to control their symptoms by utilizing this treatment. There are three key phases of adherence: initiation, implementation, and discontinuation. Initiation, which is a discontinuous action, describes the first occasion that a dose of medication is taken by a patient after it has been prescribed. Comparatively, implementation represents the extent to which the patient's medication taking matches the prescribed dosing, administration frequency, and timing, and is therefore considered to be a continuous action. Discontinuation marks the end of therapy and is indicated by the omission of the patient's next prescribed dose and doses thereafter. Next we will discuss persistence. Persistence is a measure of treatment continuity, defined as the time from the initiation of treatment to its complete cessation. It is distinct from adherence, whereby a patient who is considered to be persistent with their prescribed treatment regimen may not necessarily qualify as an adherent one. To clarify, a patient who completes a treatment regimen for an acute illness within the time frame agreed upon with the prescriber would be considered to be persistent. However, if over the course of this treatment, the patient's implementation of the regimen was disparate to that prescribed, e.g., errors in dose amount or timing, they would be regarded as non-adherent. And now let's focus on concordance. Unlike compliance, adherence and persistence, which are quantifiable parameters related to patients' medication taking, concordance relates to the nature of the relationship between clinicians and their patients in arriving at treatment decisions. First introduced in the late 1990s, concordance was heralded as a model of shared decision-making and consensual agreement between doctors and patients as equal parties. Concordance emerged from the understanding that non-adherence is often the outcome of a prescribing process which neglects the patient's beliefs and preferences. Although concordance initially focused on the consultation process, where it was expected that clinicians and their patients reached therapeutic decisions only after negotiations respecting the beliefs and wishes of the patient regarding the use of the medication had taken place, over time, the scope of the term expanded to encompass the importance of communication during consultations and patient support in their medication taking. We will now switch gears to patient-centered care. Patient-centered care is a concept which reflects the quality of health care delivered to patients and incorporates the shared decision-making attributes which underpin concordance. Like concordance, the concept of patient-centered care reflected a transition from disease-oriented understandings of patient care. It is defined as a partnership among practitioners and patients, which ensures that decisions respect patients' wants, needs and preferences, and that patients have the education and support they require to make decisions and participate in their own care. In this way, the clinician is required to assist patients in arriving at an agreed treatment decision by educating them about their treatment options while at the same time eliciting and considering their beliefs and preferences. We will now look at categories of non-adherence. Non-adherence can be categorized generally into one of two broad categories. Primary non-adherence relates to those patients who do not present their original prescription for dispensing or do not initiate an agreed intervention in the first place. It is estimated that approximately 28% of new prescriptions written by primary care specialists are never filled. Practicing pharmacists are, therefore, less likely to encounter this group of non-adherence. Secondary non-adherence refers to when patients do not take their medications or follow the implementation of a particular intervention as agreed with their healthcare professionals. Secondary non-adherence can be further classified into unintentional and intentional. Unintentional non-adherence is observed in those patients who have the intention to adhere to agreed treatment recommendations but are prevented from doing so due to reasons beyond their control. This may include patient forgetfulness or not understanding how to take the medication. Intentional non-adherence occurs when patients makes a conscious decision to cease or modify their agreed treatment after consideration of its perceived benefits and risks. In these cases, the risks, e.g., side effects, associated with the treatment are perceived to outweigh the benefits, e.g., alleviation of symptoms. Next we will discuss factors impacting adherence. There are a number of factors associated with patients' adherence to treatment regimens, and these have been explored extensively in the literature. These factors are often organized into one of 5 categories that are in line with the World Health Organization's dimensions of adherence, namely: 1. Therapy-related factors. 2. Condition-related factors. 3. Social and economic factors. 4. Patient-related factors. And 5. Health system or healthcare team-related factors. We will now shift gears to therapy-related factors. The specific nature of treatment regimens and the level of patient involvement required for their maintenance have been shown to influence adherence levels. Complex treatment regimens that involve the use of multiple medications for one or more disease states have been associated with lower adherence, primarily owing to the increased demands such regimens place on patients. Treatment complexity is not only the result of the number of medications taken by patients, but also their administration frequency, duration of treatment, dose administration form and additional directions. The lack of immediacy of beneficial effects associated with prescribed treatments may negatively impact upon patients' adherence. This is especially apparent in the management of conditions which do not present with symptoms, for example, hypertension or dyslipidemia, where treatment benefits may not necessarily be noticed by the patient. Concerns about or the actual experience of side effects resulting from prescribed treatments may also negatively influence adherence levels. Patients' inability to access appropriate medical services and medications also impacts upon treatment adherence. This relates both to patients' geographic location with respect to surrounding health services and to the cost of medications. We will now focus on health condition-related factors. Condition-related factors relate to the illness-specific demands faced by patients and have been demonstrated to influence treatment adherence. Some of the key factors include symptom severity and the level of disability caused to the patient, rate of progression and severity of the illness, and the presence of comorbidities. Patients who experience severe and impairing symptoms as a result of their condition are more likely to adhere to treatment compared to patients with largely asymptomatic conditions. Furthermore, the nature of progressive conditions such as heart failure or diabetes, and the potentially severe consequences of their mismanagement have also been shown to influence treatment adherence. Comorbidities such as depression may also impact adherence by potentially impairing patients' motivation or awareness regarding the importance of treatment regimen maintenance. Next we will discuss social and economic factors. Patients' socioeconomic status has been identified to have an important role in predicting treatment adherence, although the findings of research in this area vary depending on the specific population under examination. The costs associated with certain treatments can be too much of a financial commitment for many patients, especially those from a low socioeconomic background. The financial burden of treatment can extend beyond prescription costs and may also include consultation fees, medical test costs, and the cost of transportation to health services. This issue becomes especially pertinent for patients taking multiple medications for prolonged periods of time, as is often the case for patients with chronic illnesses, who may find it difficult to maintain the associated expenses of treatment. We will now shift gears to patient-related factors. Patient-related factors associated with treatment non-adherence have been the focus of much research and relate to patients' knowledge, attitudes, beliefs, expectations, and the resources available to them. There is a vast body of literature regarding these factors. Patients who have difficulty accepting their diagnosis are likely to reject any prescribed treatments. This is particularly prevalent amongst patients with largely asymptomatic conditions such as hypertension or those who have difficulty accepting biomedical conceptualizations for certain conditions such as attention deficit hyperactivity disorder, abbreviated as ADHD. Patients' misunderstandings about the nature of their illness and the importance of the prescribed treatments have also been reported to negatively affect treatment adherence. Patients with low education or poor literacy levels have been shown to have less knowledge about and poorer understanding of their condition and its treatment in comparison to those with higher education and literacy levels. These patients may also have difficulty accessing health and medication information that is presented in a comprehensible format. As a consequence, such patients are more likely to have lower treatment adherence as they may not fully understand the importance of the prescribed treatments and experience difficulty in finding appropriate sources of information. We will now discuss healthcare system-related factors. In comparison to the factors highlighted above, relatively little is known about how aspects of the healthcare system impact upon adherence. It is generally understood that a positive relationship between patients and their healthcare providers may foster treatment adherence. Many healthcare professionals do not receive direct financial reimbursement for educating patients about treatment adherence. This, coupled with the time demands faced by many health professionals, may lead to reduced willingness and motivation to provide adherence-related advice and support for patients. Consultations with patients may prove too short to adequately inform them about the importance of treatment adherence or to identify and address any discrepancies in patients' medication-taking behaviors. Moreover, healthcare professional abilities including training and motivation can negatively influence effective communication in fostering adherence. Problems may also arise when patients are visiting multiple healthcare providers and there is communication breakdown between them, whereby information is not relayed from one provider to the other and may present a barrier to the identification and management of treatment non-adherence. Good interprofessional collaboration is essential to avoid communication breakdown. Such collaboration, whether by face-to-face contact, telephone contact, or the sharing of patient treatment records, can lead to more holistic patient care. In this way, treatment plans can be optimized when necessary and each healthcare provider can and be better equipped to monitor and manage patient adherence. WED will now look at factors promoting adherence to prescribed medications. The findings of adherence-related research have predominantly focused on factors which negatively impact upon adherence. However, there is an increasing trend to investigate factors that encourage adherence to prescribed treatments, which is important as a step towards intervention development. See below. Some of the factors that have been associated with high levels of adherence include patients' feelings of certainty associated with the use of medications, trust in the physician and/or the medications, fear about potential health consequences associated with lack of treatment, motivation and desire to control their health condition, and confidence in their ability to self-manage their health condition. Other key promoters of treatment adherence relate to patients' knowledge and understanding and their beliefs about their health condition and its treatment. And now we will look at interventions that promote adherence to therapy. There is no single intervention guaranteed to address the issue of treatment non-adherence. Although there are several interventions which have been demonstrated to significantly improve medication adherence, the consensus in the current literature is that their effectiveness will vary depending on the nature of the intervention itself, the way in which it is utilized and the specific population the intervention is targeted at. Consensus seems to exist, however, that multifaceted interventions are more effective. In order to develop interventions aimed at improving adherence, it is important to consider several factors. Firstly, non-adherence is not associated with a specific disease state. The vast body of adherence-related literature emphasizes that non-adherence is ubiquitous amongst a broad range of diseases and is especially apparent in the treatment of chronic illnesses. Secondly, there is no specific non-adherent patient. There may be some patient characteristics that are associated with non-adherence, but it is not possible to predict who will be non-adherent. There is likely to be inter-patient variability in adherence, but there is also intra-patient variability in adherence, i.e., where the same patient may have varying degrees of adherence to prescribed regimens over time and across different treatments. It is also important to note that the link between patients' characteristics and non-adherence is very much dependent upon the nature of the condition of interest and its treatment. Therefore, these associations are rarely generalizable to the entire population. Thirdly, non-adherence is likely to be the result of more than one factor. For example, regimen complexity, lack of clear information and incompatibility with patients' beliefs may all contribute to non-adherence in one patient. Therefore, interventions need to consider the factors that may be contributing to a patient's non-adherence, and be tailored to address the individual needs of the patient. We will now discuss educational interventions. The overarching aim of educational interventions is to provide patients with access to understandable verbal and/or written information about their health condition and the prescribed treatment. In these instances, it is anticipated that improved patients' understanding will lead to improved adherence. However, it should be noted that greater patients' understanding about their illness and its treatments may not necessarily lead to better adherence, as it may not be the sole factor influencing patients' willingness to adhere. Educational interventions generally involve one or more of the following. 1. Let's begin with face-to-face discussions, where healthcare professionals can provide targeted and tailored information to patients, and address barriers to adherence. 2. Next we will look at educational booklets. Provision of booklets containing general information about particular health conditions, signs or symptoms, causes, consequences, and their treatments, mode of action, side effects, to patients. 3. And now we will discuss electronic informational leaflets or brochures. A variety of patient information leaflets relating to various conditions are downloadable from the Internet and may supplement verbal and/or written information provided to patients by their healthcare professionals. 4. Regarding specific information leaflets, patients may also be able to access disease and treatment-specific information leaflets prepared by pharmaceutical companies or independently prepared by some pharmacies and doctors' surgeries. 5. Consumer medicine information, abbreviated as CMI, or package insert leaflets, abbreviated as pills, CMI or pill is a standardized and comprehensive form of medicine information for patients which is available either as an insert in the medication's packaging, printout or electronically. Next we will look at behavioral interventions. Behavioral interventions generally involve assisting patients in developing necessary skills required to meet the demands of the prescribed treatment regimen. These interventions attempt to broaden patients' capacity to manage their illness and its treatment not only by skill building, but also through the issuing of reminders and providing simplification of treatment regimens where possible. Some examples of behavioral interventions are: A. Motivational counseling. This form of healthcare provider-initiated counseling, also referred to as motivational interviewing, uses a patient-centered approach to help initiate change in particular behaviors, e.g., medication-taking habits. The approach is based on the Stages of Change model, which proposes 5 stages of change in relation to patients' health behaviors. 1. Pre-contemplation. 2. Contemplation. 3. Preparation. 4. Action. And 5. Maintenance. These stages should be used by healthcare professionals to guide their attempts at improving adherence. During motivational counseling, it is essential that the healthcare professional collaborates with the patient to explore potential reasons for low adherence and identify mutually agreeable goals to address these issues. To achieve this, it is important to assess the patient's readiness or willingness to change and to make recommendations based on the identified barriers to adherence that are in line with the patient's state of willingness. It is useful for healthcare professionals to be able to express empathy towards the patient, which will assist in understanding the patient's perspective and increase patient comfort. Responding appropriately to patient resistance during motivational counseling is also important. Healthcare professionals should not engage in arguments with their patients. Rather, they should take time to explore the patient's reasons for resistance and emphasize the need for change in the context of the patient's goals. In doing so, healthcare professionals will help foster the patient's self-efficacy, which is a key driver of patient adherence to prescribed regimens. B. Next we will consider specialized packaging. Specialized packaging of prescribed medications has been found to help improve patients' adherence, particularly in instances where patients' non-adherence is the result of forgetfulness. Dosing aids such as calendar blister packages, pillboxes or Webster packs, which involve the packaging of several medications in a fixed combination to be taken together, can assist in better organizing patients to take their medications. Other strategies to organize patients' medication taking include medication calendars or reminder charts, which instruct patients to take their medications at the same time each day or help associate their prescribed doses with other daily activities such as consuming a main meal. And now we will consider adherence reminder aids. These strategies focus on regularly reminding patients to take their medication or medications and include setting reminder alarms, e.g., on a mobile phone, electronic devices. They also include strategies that remind patients to collect their repeat prescriptions from the doctor or pharmacy, such as telephone, mail or text reminders. D. Regarding regimen simplification. This is a common approach used to help improve patients' adherence, particularly in instances where a patient's regimen involves multiple medications, as this may increase the risk of unintentional non-adherence. Studies highlight that reducing the complexity of prescribed regimens by decreasing the quantity of medications or their administration frequency leads to significant increases in adherence rates. Therefore, where non-adherence is identified, it may be beneficial for pharmacists to review the patient's regimen to screen for medications which 1. may no longer be necessary, or 2. can be substituted for a non-pharmacological alternative, or 3. can be substituted for an extended release or long-acting formulation to decrease dosing frequency, or 4. can be substituted for a combination product containing 2 or more medications in one tablet or capsule to decrease the number of medications, or 5. can be administered at the same time. And now let's focus on intervention design. The Perceptions and Practicalities model of non-adherence was proposed by Horn, and provides a conceptual distinction between patients' variations in medication use. The model can be a useful guide for the development of interventions to improve adherence, where the interventions should focus on addressing both the perceptual and practical barriers which may influence patients' medication adherence. The core aspect of the model is the recognition that non-adherence may be intentional, i.e., the patient won't take the medication, or unintentional, i.e., the patient can't take the medication. The model highlights that intentional non-adherence stems from deliberate patient decisions to alter their medication use, whether by modifying the dosing frequency or not taking the medication altogether. These decisions are based upon the incompatibility of the prescribed treatment with patients' own beliefs about their illness and treatment, as well as their perceived expectations of outcome. For example, where a patient does not understand the need for a particular treatment, e.g., the use of inhaled steroids for the treatment of asthma while asymptomatic, it is unlikely that they will adhere to therapy. In this way, intentional non-adherence can be viewed to be the result of perceptual barriers influenced by patient beliefs. Comparatively, unintentional non-adherence is a consequence of practical barriers which prevent patients from taking their medications as prescribed. These practical barriers relate to patient capacity and/or resource limitations that may lead to non-adherence despite patients' intentions to follow the prescribed regimen. Such limitations may include deficiencies in 1. memory, e.g., patients who forget to take the medication or forget regimen instructions. 2. Dexterity, e.g., patients who have physical difficulty opening medication bottles or boxes, or those who struggle using medical devices such as inhalers. 3. Knowledge, e.g., patients who do not understand regimen instructions or the need to refill prescriptions. However, it has also been suggested that there may be a gray area between intentional and unintentional non-adherence, which represents those cases where apparently unintentional non-adherence results from intentional non-adherence, i.e., the patient claims to forget, but the real reason is because he or she does not value the severity of the underlying disease. And now we will progress to the pharmacist-patient relationship. The aim of this section is to provide the pharmacist with some practical tips to be used during the patient encounter to identify and foster medication adherence. We will now progress to methods of identifying non-adherence in healthcare consultations. There are a range of factors which may influence patients' utilization of prescribed treatments. Therefore, it is important that pharmacists are able to recognize potential indicators of non-adherence and are able to address any concerns patients have about the prescribed regimen as promptly and appropriately as possible. These indicators are closely related to the previously explored factors associated with treatment non-adherence. Healthcare professionals often overestimate their patients' adherence, and when coupled with the fact that patients are generally reluctant to disclose non-adherence, many instances of non-adherence can often go unnoticed in practice. To avoid this, familiarity with indicators of non-adherence is essential, and these are outlined in Table 5.1. The lists are not exhaustive. Pause the video and carefully scrutinize Table 5.1 summarizing indicators for potential non-adherence before advancing to the next slide. Pause the video and carefully scrutinize Table 5.1 summarizing indicators for potential non-adherence before advancing to the next slide. We will now look at how to measure patients' adherence. Whenever patients interact with a healthcare professional, regardless of the reason, whether it be for a follow-up appointment, blood test, or simply refilling a prescription, there is an opportunity to discuss medication taking behavior. Regular review of patients' medication use and ability to systematically document therapy adherence at each visit is of utmost importance for pharmaceutical care. In addition to the potential indicators of non-adherence, there are a variety of tools and methods designed to assist healthcare professionals in assessing patients' adherence to their prescribed treatments. These methods can be categorized as direct or indirect, and the latter further differentiated into either objective or subjective measurement approaches as outlined below. And now let's discuss direct methods. Direct methods of adherence assessment are regarded to provide the most accurate estimates of patients' adherence levels. Some examples of these approaches include: 1. Direct observation of therapy involves physically observing the ingestion of the prescribed medication. 2. Assays of biological samples involves the measurement of drug or metabolite concentrations by assaying patients' saliva, urine or blood samples, or measurement of drug biomarkers. These approaches have clear advantages, the most important of which is their accuracy in determining patients' adherence levels. However, they can place an increased burden on the supervising healthcare professional and can be quite invasive for many patients, making it difficult to utilize these strategies in routine day-to-day practice. We will now focus on indirect methods. Indirect methods are easier to implement and less invasive compared to direct methods, although they may not provide adherence estimates of the same accuracy. These methods can be classified as objective or subjective, depending on the specific nature of the investigative approach, the former providing more direct assessments of adherence rates. We will now talk about objective methods. 1. Let's begin with pill counts. This method involves healthcare professionals determining the number of unused pills remaining in patients' medication bottles or blister packs. If the number of unused pills is greater or less than what is expected based on the patient's prescribed dosing regimen, this may indicate that the patient is potentially under or overdosing, respectively. Pill counting is generally quick and easy to perform, providing an objective assessment of patients' adherence to their dosing regimens. However, the accuracy of the results may be affected, for example, by patients discarding a certain amount of pills prior to appointments with their healthcare professional in an attempt to appear congruent with the regimen. Patients may also place pills in other containers such as pill boxes, which would also affect pill count findings. Another disadvantage of this method is that while it allows quantification of the total number of pills consumed, it does not provide insight into whether patients are taking the prescribed doses at the correct time throughout the day. 2. Next we will consider pharmacy refill records. The use of pharmacy refill data provides insight into whether patients' prescriptions have been filled and the regularity with which this occurs. From this information, pharmacists can determine the number of days that a patient has been without their prescribed medication, based on the prescribed regimen and the number of pills supplied with each refill. Refill data are readily available and hence, commonly utilized in the community or hospital outpatient pharmacy. Pharmacists are able to examine patients' electronic prescription records, make assessments about their adherence and follow up with patients where necessary. It is economical and non-invasive. However, the major drawback of utilizing this method is that it does not provide detailed insight into patients' medication-taking behaviors. Computerized patient records may highlight when a prescription has been refilled, but they do not indicate whether or not the medication was actually taken by the patient as prescribed or even taken at all. Furthermore, several refill records must be examined before any meaningful patterns in the patient's medication use can be identified, which also requires patients to refill their prescriptions at the same pharmacy. 3. And now we will consider electronic monitoring devices. Electronic medication monitors are recognized as the gold standard for the measurement of adherence to medications, although their use is also not without potential faults. The Medication Event Monitoring System, abbreviated as MEMS, is a common electronic monitoring device which consists of a chip inserted into the cap of the patient's medication bottle and is capable of recording the dates and exact times that the bottle was opened. The saved information can then be downloaded onto a computer and analyzed to determine how accurate the patient was in adhering to the timing and frequency of the prescribed doses. More recently, dosing aids including a chip to record the same information have been developed. While these devices provide detailed, accurate information about the patient's dosing frequency, they rely on the fact that with each opening of the medication bottle, the patient is removing the correct number of pills. This may not necessarily be the case, as patients may often remove the total number of pills they need to consume for the duration of the day at the same time, rather than opening the bottle on every occasion that a dose is required. Another drawback is that, as with all indirect methods, they do not document whether a patient actually ingested the dose that was removed from the bottle. Furthermore, these devices are expensive and therefore are not used routinely in clinical practice. Importantly, these devices lead to an initial artificial change in patients' medicines taking behavior, leading to their potential use as an enabling strategy. And now we will discuss subjective methods. 1. Let's begin with interviewing. Interviewing patients about their medication use is an easy-to-use approach to assessing medication adherence and should be routinely used in practice. In doing so, it is important to use a combination of open and closed questions to elicit information about the patient's treatment utilization and their beliefs about the treatment. Pharmacists should be empathic, adopt a non-judgmental approach and word questions carefully during these discussions, to increase patient comfort and elicit accurate information. 2. Next we will look at patient questionnaires. The use of other patients' self-report measures such as patient questionnaires is another practical approach to measuring adherence, although the results obtained may not be as rich as those obtained through patient interviews. Questionnaires are economic, unobtrusive and generally time-efficient, but as with patient interviews, they may lead to biased or inaccurate information depending on the truthfulness of responses. Most questionnaires have been primarily created for research purposes. However, many are now available for use by healthcare professionals and can still provide useful insight into patients' medication taking. When using questionnaires, pharmacists should first evaluate what is being measured, as some focus on beliefs and others on the actual adherence measurement. 3. Next we will look at patient diaries. Asking patients to keep a medication diary is another easy-to-use, cost-effective method for estimating patient adherence and identifying potential barriers to adherence. The diaries may be structured or unstructured and may assist in capturing more than just adherence-related information, but also information about their beliefs and preferences. As with the remaining patient report measures, This approach is susceptible to misrepresentation as it relies on the accuracy of the patient's accounts. Thank you.